Good afternoon and welcome. And I'm hoping that the energy and conversation I can hear in the room will continue, because what we're looking for is an inclusive and interactive session on an incredibly important topic at an incredibly important moment in time. Good afternoon, everyone. My name's Nnenna Osuji. I'm delighted to chair this panel. And I want to start off by talking about the first time I learned the difference between equality and equity. I remember it. I was at Birkbeck. It was one of those moments that really changed how you planned, what you did, and your purpose in life. I had another aha moment in the midst of the COVID crisis, where as medical director, I was looking at the names of people who had died. And they all had a very non-British sound to them. It really gave, I still have shivers when I think about it. And that was a moment that we thought, juxtaposed to the George Floyd situation, that we thought was global reckoning. A moment that should have turned the tide on where we stood on health inequalities and on race discrimination. A moment where we would have said, not again. And I think it was incredibly sad that last year, we ended up in a situation where, with just minimal provocation, what surfaced seemed to be subliminal but persistent racist discrimination and religious discrimination. I think that really highlights for us that this is a topic that has not gone away, and a topic that we need to not be backwards about standing and stepping forward on. I am joined by a really august panel today, and I would like us to have a different conversation, not the same conversation. I'd like us to have a conversation that's going to take us to action and commitment. So I am joined by Sharon Allen, who's the Chief Exec of Arthur Rank Hospice Charity. Sharon brings with her years of experience as previous Chief Exec for Skills for Care, and also has worked in the housing sector. So I love the richness of the conversation that we're going to have. No pressure, Sharon. We're also joined by, many of you will know, Julian Hartley, who joined the CQC in December. Can't believe it's only been 3 months. Prior to that, NHS providers, and a very long established history in the NHS in Leeds and in other localities. Stephani Hatch is a professor at the King's College London. She's Professor of Sociology and Epidemiology and Vice Dean for Culture, Equity, Diversity and Inclusion. So what I'm saying to you is we have an incredible panel, and when you're ready to ask them questions, do pose difficult questions. Don't give us anything easy. I also reflect on the constitution of our panel, 75% women, 25% men, very reflective of our NHS workforce. So we're reflective in every sense. When we were speaking about chairing this panel, we spoke about the stereotype. As a black woman, was I the person to chair this panel? I'm not just a black woman. I'm also a medic. I'm also a mother. I'm also a leader. And as a leader at this moment in time, this is where we should be having this conversation. So I chose to sit here today. And what I'd like us to do is to give oxygen, not just air, to the conversation on racism. I'm going to invite Stephani to lead us off on some thought provocation.
Thank you so much. And thank you to the organizers for inviting me today. Because I am a sociologist and an epidemiologist, I'm going to, context matters to me. And so just like was just shared, what you won't see in my bio is that I was raised in the southern part of the United States in Atlanta, Georgia. I migrated to this country 20 years ago, and I am the daughter of a retired nurse. So a lot of the work that I'm going to present today was inspired by what I saw growing up of, my mother's experiences, my cousins, my aunties experiencing, who were nurses in the US, and the racism that they faced in healthcare. and how unfortunate it was that when I migrated to this country and started doing work around health inequities and inequities in health services, that I saw much of the same things repeated. So we're very fortunate in this country to have an NHS Race and Health Observatory. And if you haven't engaged with it, I strongly suggest that you do. I am, a disclaimer, I'm one of the board members, and we're very proud of the work that has been going on for now coming up to 3 years. And what they have been highlighting are the ethnic inequalities right over the life course that we see in terms of health and health services. And you see that across multiple areas of health. So if you think about, as we were going through earlier this morning, the various areas from primary care all the way through various secondary care and in hospital settings, social care, we see much of the same patterns persisting. My own group has been focused and has been publishing both in academic literature, but also more general population pieces about racism and bullying and harassment and discrimination. They tend to coexist together, and they take a terrible toll on those from ethnic and racial minoritized groups. And in fact, the group who's most affected are nurses, and we also work with midwives who experience the same. But your nurses, who I haven't really heard a lot about today, we've talked about the doctors, we've talked about the various, your nurses are the ones who are carrying the brunt of this treatment. And what impact does it have? So we've had the workforce race equality standard for a number of years, and those metrics have not gotten any better. Just let that settle in, but we've not done much about it. We know what the problem is. We know from the NHS staff survey, along with some of your HR data within the NHS, that tells you that people are experiencing these things. But what we were able to do is then to look at what is the impact of being unnecessarily exposed to racism and discrimination, not just acutely, but cumulatively over time. It has a pervasive impact on staff's health, and particularly mental health. This often leads to longer periods of sickness absence. So when I'm in a room with NHS COOs and CFOs, and they're sort of, looking down at their papers or on their phones, I remind them, this should matter to you because this is losing you money. This is losing your trust money. This is a huge part, a tractable problem that we can do something about. And we know that what this leads to are other problems in terms of career progression. So underrepresentation in senior roles, more likely to face disciplinary action, and poor staff retention. I work with groups like Equality for Black Nurses who provide legal and emotional support for nurses who are going through disciplinary action. And it is heartbreaking what people are dragged through. And we've seen in recent times, accounts of this, these qualitative accounts of this, but they get quickly forgotten. So I want us to remember those today. You probably have a story of your own that you can recall from the trust that you're working in, the hospital you're working in. And think about where the fairness was in that process, because we know time and time again, the finger is immediately pointed to those from racial and ethnic minoritized groups in comparison to their white colleagues. And we now have evidence of this. So we've been using methods like virtual reality to look at different ways of engaging on this topic. And one of those ways is through what we call walking in the shoes of. And that VR experience not only helps managers and leaders experience firsthand what many of us have had to go through from a very young age, from the time we entered into education, but it also allowed us to, sort of, in terms of witnessing the discrimination, to get some hard evidence to back up what people often dismiss as just perceptions. So an example of this is the VR allows us to look at eye tracking. So I'll give you a quick example. We present people with a scenario, and these all came out of the pandemic. So this one in particular, we show them where a black male nurse is just simply asking for PPE. The white managers and colleagues, and these are based on qualitative narratives that were shared with us during the pandemic. They're standing in a corridor. The white managers and nurses are being aggressive, not only in terms of the volume of their voice, but hitting the wall. We show these to teams of people working within a trust. And what we found was very startling. 90% of them, when asked after the video, who should be held, who should be brought forward in terms of disciplinary, they all said Tunde, the black male nurse. We showed it back to them, and we looked at the eye tracking. Not one of them had looked at the white colleagues. They were all focused on the black male nurse. And we're quick to jump to this conclusion that he had to be in the wrong. And I want you to think about that, because this is the way in which biases sort of enter into our everyday social interactions within the workplace. We not only think about the workforce, but we also think about the unpaid carers, because oftentimes those in the workforce also have caregiving roles. And so if you think about that double disadvantage or triple disadvantage, we know that there's also poorer health related to being an unpaid carer. There's more likely for you to be unemployed and have financial strains at some point. There's a lack of racially inclusive support and poor access and mistrust of services. And this is against a backdrop of a series of systems of oppression. Now, I'm focusing on racism today, but I want you to think about the intersection and how people actually experience these things. It's not in isolation. So if you look at these circles and how they're overlapping, for many people, it includes a lot of these experiences all at once. I am not just I'm not just a woman, I'm not just Black, and I'm not just a migrant. I'm all of those things all at once. And when I walk into a room, people decide how they're going to treat me. Today I have a badge that says I'm a professor, and that has made, whatever difference it's made, but that's usually not the case. So when I'm in the health service, I get a very different treatment. That's my personal experience. And so what we want you all to do to think about today is how you're going to stand up against racism, particularly in the workplace, because I'm not talking about eradicating racism. Right? We know that that's a much bigger societal problem, but I want you to think about people being able to come to work and have respect and dignity and be able to carry out their jobs and not be unnecessarily exposed to a source of adversity that is going to impact their health. One of the ways in which we look at this issue, and people often ask me when I come into these rooms, well, I don't know what to do. I walk away and I don't know what to do. I'm not comfortable having the conversation. I wouldn't know how to have it. I don't want to stand out in a room full of other leaders and managers. And I'm asking you to do just that. And I'm going to give you 3 things. And this is work by Dr. Kamara Jones, who is a medical physician in the US, pediatrician, but also was the president of the American Public Health Association back quite a while ago. But what she did was make racism a public health crisis. And that really introduced this idea that 3 steps that she'd asked people to take, and we're gonna go through those today. But first, I want to make sure we're all on the same page, because I think that when we talk about racism and we talk about anti-racism, oftentimes people struggle to define what they mean by that. So this is just one simple definition. So what we're really talking about here is a system, not about you as an individual. That's why I use anti-racism and not anti-racist, because immediately that puts people's backs up. What we're talking about is a system of oppression where it is about structuring opportunity and assigning value based on the social interpretation of how one looks. So that socially constructed variable around race. And when I came to this country, people said, no, 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 don't use the word race. And it wasn't until 2020 that things started to shift. All of a sudden, people wanted me to talk to them about race and racism. When I had been saying, no, I'm going to use the word race when I am referring to a phenotype, when I'm referring to skin color as one example. But simply put, racism unfairly disadvantages some groups, it unfairly advantages other groups, and it saps the strength of our whole society. And in this case, it saps the strength of our health and social care abilities and our resources that we could have access to. And that process through which this comes to be is racialization, which people don't think about. They think about racism in this sort of, this bigger thing over here. But there's actually this process and mechanism that's really important here. And it's this process of othering. So it's not just about, where you're situated at one point in time. And we saw this after Brexit. It's also the process of othering. So groups that become minoritized. So one thing we saw locally in Southeast London after Brexit was the similar reporting of levels of discrimination. So the prevalence of discrimination, not just experiencing it, but witnessing it and anticipating it. So by anticipating it, I mean not going for the jobs, not going for education opportunities, because I've seen other people who look like me get treated unfairly. So we saw this rise among those particularly from Eastern European countries. And that was the only explanation. All of a sudden, they had been othered post-Brexit. And we saw it with other groups as well. But it's quite, and we've seen it happen in the US after 9/11 and other, big social events. These things are worth paying attention to. And I want us to also think about the mechanisms. So the reason why I focus on discrimination, because it's often the way in which racism is enacted. Okay, and we know that it's an exposure, as I mentioned, that has a life course narrative. It's shaped by multiple statuses, as I've mentioned, deeply entrenched in institutions and social context. It limits our life chances, and it is all interrelated. As I've just mentioned, don't just think about experiencing it, but we've actually shown that witnessing discrimination impacts your mental health. So there's also these consistent relationships that we cannot model away. There's nothing I can put into a quantitative model to explain away the impact of discrimination. We're I can't even get it below a twofold difference. And that's how strong it is. But it's a source of stress. It's a stressor that does not get attended to. The number in qualitative interviews, the number of service users from racial and ethnic minoritized groups that we talk to that say, no one has ever asked me about the experiences that I've had with regard to racism, with regard to discrimination. So building on some of our work and our Tackling Inequalities and Discrimination in Health Services, or TIDES study that was funded by Wellcome, we've recently been given a Discovery Award. And someone asked me, do we need more research? And I would say, yes, we do. For a start, there is a huge disparity in terms of studies that have been published around racial and ethnic inequalities in this country. Some of the data just sits in, filing cabinets, and journals don't want to publish it. It has only been recent, since 2020, and we should have been very ashamed of ourselves when the pandemic hit, and we didn't know much about, people were, talk after talk after talk, and they're saying we don't have the data to understand the background of why we're seeing the disproportionate impact on those from racial and ethnic minoritized groups. Not collecting, data on ethnicity We are now over 20 years since we've had a nationally representative sample on population mental health that allows us to disaggregate ethnic and racial groups. The Adult Psych Morbidity Survey had a plan this time. They were going to do a booster sample. We were going to correct this problem. And Department of Health and Social Care realized that it was going to be too expensive. So once again, I'm going to sit down to analyze those data and have to aggregate everyone together as if we're all the same. So this is some of the things we're tackling within this project, but it's mostly around collective systems approaches, cross-sector approaches to trying to reach some level of race equity that we've not reached before. Because who cares for those who care? That's the question we keep asking ourselves. And we've had people bring up the workforce, and we hear it. I go and I give my talks, and I sit on advisories with NHS England and other groups, and we all bring up the patients, and they're very important. But what we miss out is the workforce, the staff, first and foremost. And I say to people, if your staff is unwell, how do you expect, or they're living in chronic conditions of bullying and harassment? Because it's the bullying and harassment, not by the families and the patients, that has the biggest impact. It's the bullying and harassment by their colleagues and managers. And that is allowed by leadership to occur, and there is no accountability. So those are the questions that we're asking. And so I'm asking you here today to engage in some anti-racism action. We must work towards towards three things: structural, systemic, and cultural change. Yes, the cultural change is difficult, but you've got to stay at it. People create the culture. It doesn't create itself. It's not something imaginary out there. We need to challenge racialized organizational norms. We need to think about the fact that this is impacting all staff, not just those from racial and ethnic minoritized groups, all staff, including those from the majority group. I'll tell you this story. The work we've been doing around student nursing, right? They start off, we interviewed them, in-depth qualitative interviews. They start off talking about how wrong the behavior is, how no one should be bullied and harassed, how all of these things are intolerable and that they're going to be different. Their generation's going to be different. We follow them up after a couple of years, and they're like, it's just the way it is. And I've got to get on. And the white student nurses talk about how they benefit from their whiteness. So one of the things that we can do today in a room full of policy-oriented people and people taking action in policy is to just look at your policies through a different lens. So here I'm talking about using this confronting institutional racism policy review framework. This is just one way of doing it. And it goes back to one of those three little bubbles, and it is about understanding how is racism operating here, asking that question. Looking at the structures, looking at the policies, and looking for the how that we were talking about earlier. Looking at the practices, how are things actually done? What are the norms and values? How are they underwritten and embedded? Also thinking about the four types of mechanisms that may be at play. So looking at how policies, have unintended consequences, right? We all know that sometimes, but looking at it deeply through this equity lens and really trying to focus in on how we can make changes and make them more fit for purpose for everyone. And then I want us to, really think about moving to the how. And that was sort of my favorite part of the discussions earlier. So, we've described the problem, let's focus on the how. Like really get underneath the bonnet a bit and think about how these things play out. How is it that you're seeing this career progression? We know that there's issues with underrepresentation in senior roles. I'll use that as an example. So one of the things that we're looking at is where's that sort of hidden curriculum or those hidden aspects of engagement that happens in the corridor, that happens, at the dinners and all of those things that makes people move ahead, that sort of unfairly advantages some over others. So really looking at this idea that Lincoln Garcia had around inequality diversions. And it's one of my favorite things to focus on now. So yes, it's important that we focus on those who have been most affected by these inequities. But we also need to be paying attention to how the groups that are advantaged are maintaining that advantage. And it's really important here because this has been persistent. And so one of the things that we like to say now is that we research resistance. We are researching resistance to change, not the levers of change, because I can identify those, but it's about the resistance and what part are each part of the system and individuals and leaders playing in that. I want you to leave here today with a commitment to inclusion as a practice. Because you see, diversity is the bare minimum, right? We should be focusing on inclusion as a practice, as a verb, with equity as our ethos and our guiding principle. So it then takes what everyone wants to make, EDI or DEI or however you want it, which way around, wants to make it something to write off. But actually, when you look at the nuts and bolts of it, this is what benefits us all to make sure that we're making the most. So these are some of the ways in which I think we can make that happen. And I want us to have more accountability in leadership. Everyone I've talked to today, one-on-one, I keep bringing up this word because I do think that leaders need to be held more to account. And what we hear mostly, in terms of what goes on in trusts, what goes on in practice, primary care practices, et cetera, is it's not the leaders at the very top, because they generally don't, have as much influence as they think on what's going on the ground. It's those middle managers. So we need to be able to hold people to account. And if you are the person at the top, what are you doing to ensure the psychological safety of your staff, and in some cases, the physical safety? This is all a part of it because you're leading everyone. So the onus is on the leaders, the organizations, and the institutions across sectors to think about and to also to be able to demonstrate how you are not enabling these systems of oppression. So I'm going to leave you with these 3 circles here today. So these are your 3 steps for homework. If you do one thing, and if you take one thing away from what I've said today, it's just this. Don't be afraid to name racism where you see it. Ask the question, how is racism operating here? And then I want you to get with your colleagues and collectively organize and strategize to act. Thank you.
Stephanie, thank you. As we sit here today, it's important to recognize the global context where leaders of the Western world are actively encouraging us to step back from this agenda, and where the response of the world almost immediately from big companies has been to do exactly that. This is an important moment in time. I'm really also conscious as you speak to us about naming racism, that we all use different language. Some of us use nouns, some of us use collective nouns, some of us use verbs to describe this. Whatever we want to say, it is more important that we name the issue. So let's be clumsy, but with curiosity. And I think that's what I will encourage when we're asking some of our questions. I think we know that this is about staff, it's about patients, it's about outcomes, it's about equity. And I'd like to ask my panel, why is it that of all the amazing panels that are available at the Nuffield Summit that you've chosen to sit on this one, and perhaps give a little reflection on your journey and experience so far. So Sharon, if I can start with yourself.
Yes, thank you. And when I was thinking about what to say today, I kind of realised that 40 years ago, I was starting my social work training, and one of the first sessions we had was about the impact of oppression, a really important element for social workers who are often working with people who are the most marginalised in our communities. And I have to be honest with you and say back then, even though I was classed as a mature student because I was 24, I wasn't very mature in life experience. And I hadn't really thought about it. But I took part in the training and I listened to my colleagues, and I was kind of shaken to my core. And it had a massive impact on me and made me determined that I had to do something about this. It wasn't right. As you say, it saps everybody's strength. It's unhealthy for all of us. And so I determined that through whatever it was I was going to do, I was going to be actively anti-racist. Have I therefore managed to create organisations where racism is not an issue? Sadly not. But I do hope that through my leadership and through my focus and the naming, which I do regularly, that we are having those conversations. And just recently, I was at an event, which I'll perhaps say more about, that took place in Cambridgeshire, about an initiative we want to do as a system. And at the end of it, I went to speak to two women who had fed back from their table because I was sad about what they had shared, and they told me more, which made me even more sad. And I asked them, what can I do as a leader in this system to support you? Because they worked in other parts of the system. And one of the things I did was went back and in my fortnightly update to my colleagues, talked about this and said, if there are colleagues here in the hospice who have had these experiences, please come and talk to me. And somebody did. The good thing is, somebody did. The bad thing is that she was telling me about experiences I didn't want to hear were happening in my charity. So it's an ongoing commitment that we all must make.
Thank you. Julian, you've had a long tenure in the NHS, and one of the things I always remember about you is your commitment to continuous improvement.
Yeah.
I listened to Sharon's story, and I might describe some of the things she was hearing as never events.
Yeah.
I'd be really keen to understand both your experience that's brought you to this panel, but also about how we apply that sort of never event lens and continuous improvement methodology to some of where we are.
Thanks, Nnenna. So I wanted to be on this panel because I knew I think it's the challenge of our age, frankly, and I think that it's personal. So what you said, Stephanie, about context and growing up where you did, I think in the spirit of this and picking up Thea's challenge about this morning, about no-go areas. So I grew up in a place called Bingley in West Yorkshire in the 70s and 80s. And you know, for white men of my age, you're thinking about what we were watching on the television as kids. You think about some, the sitcoms that we'd watch and that the parents would watch. It ain't half a hot mum rising damp, all that. And I mean, understanding we were part of a kind of racist set of tropes and themes as part of that, and an understanding that the journey that I recognise I've been on, inevitably we're a product of our early conditioning and the kind of deep programming. And I think it was really when I had the benefit of having much later a reciprocal mentoring with a an emerging female black leader called Kira, where we described, you referenced, Stephani, life courses. So we talked to each other about our life courses. So I was able to have this conversation about my experience growing up, my parents' attitudes, those are my friends, and then thinking about just the different points in my life where I suppose the scales fell from my eyes. So one of them was, I was fortunate to go to university, studied English literature, which the curriculum was largely dead white men, but there was a beacon of a module led by a Professor, Diana Collicott, and it was female black American writers. And it was the first time that I'd really understood and kind of got some insight to the experience, and reading particularly Toni Morrison, Alice Walker, but then also the poetry of Langston Hughes gave me a completely different lens on the world, frankly. And I think education is a massively important part of this. So I would say all of us, each of us as individuals, because I think as leaders there's a responsibility for us to be curious, as you said, Nnenna, to go on a journey of understanding and discovery. But all of that sort of journey led to a kind of culmination of the crisis, and you mentioned it in your introduction, in May of 2020. And if we all cast our minds back, that was the sort of height of the first wave of the pandemic, but it also coincided, of course, with the murder of George Floyd. And in Leeds teaching hospitals, a good 18 to 20% of our ethnic minority staff, and the shocking impact of that. Every Monday morning, people were used to me sending out something called Start the Week, which was a kind of message of what's going on, what's happening. And on the Friday, after the shocking event, murder of George Floyd, I thought, I need to say something about this. But I was struggling to frame it, to think about how to address this. And what made the difference, because I think I'd understood and benefited from the conversations I'd been having with Kira, was talking to her, but then also to Esther Jamera, who chaired our Race Equality Network, about help me frame this, and how can we address this together. So the message that went out on the Monday morning was to acknowledge there was racism within the organisation, to ask for everyone to have conversations to promote conversations between white colleagues and ethnic minority colleagues in the organisation, to be human about telling each other stories, and to pick up your point, it's okay to get it wrong, it's okay to be clumsy in the conversations, but just have a go. Because I think part of the problem for my kind of generation of white male leaders is not wanting to have the conversation in the first place, feeling anxious about that, fear of getting it wrong. So creating an environment in which it was okay to talk about this. And what that message did on the Monday morning was liberate a strong sense of a bit like the gates being open to much more open conversations. And given the terrible news about George Floyd and the importance of the Black Lives Matter movement and so on, it opened it all up. And it resulted in a really good a book, which was a gathering of the testimonies of our ethnic minority staff that had experienced racism in their careers, the things you were describing, Stephani, microaggressions, but also the impact of the pandemic. Those were gathered together in a book, which, Amplifying Voices, Mending Divides, which through stories, through narratives, there's a lot of power in that, rather than some of the more sort of fact-based, numbers-based. So there's power, I believe, in the narrative of on this agenda, as well as absolutely the kind of the things you were describing, Stephanie.
So I'm going to come back to you on continuous improvement.
Yeah, sorry, I didn't.
That's all right. No. I think there was an important story to be told, and in that there's something about doing nothing not being an option and doing it scared that has really helped to release. So thank you for sharing that. Stephanie, I'm really conscious that as if they knew it was the Nuffield Summit and as if they knew we were going to be having this particular panel, the Race and Health Observatory just released today the cost of racism. And I think there's a real need for us to use data in the conversations we're having, but I think, as Julian has just alluded to as well, also the stories. I wonder, and I asked you the question about, do we need more research?
Yeah.
We know the findings, they have been shared, but I think you've given the answer about where we need that data still. But how we use that data, where we monitor that data, and how we tell the stories. I wonder if you can give us some advice about how we can be more impactful with data.
Yeah. So I'm fortunate in that I was trained methodologically in epidemiology as well as both quantitative and qualitative methods in sociology. And so for me, it's always been about there's this great campaign that an organization in the US uses, the Institute of Women and Ethnic Studies, called In That Number. And so I always utilize the qualitative narratives, not just as data in their own right, and they're very powerful. And in fact, when I'm speaking to policymakers, it's usually the qualitative data that sort of draws them in. But I also think it's the quantitative data gives us this overarching picture, and it allows us to look over time and where we can in granular detail. So I think they've got to be used together. And I think they can be used together in very creative ways. So I gave that example of using the virtual reality. Now, I don't know anything about that. Virtual reality wasn't my area. I was looking for a more creative methodology to engage not only with communicating the data and disseminating it, but also engaging around training and education and in, having something in a meeting that goes beyond what we've all sat through in terms of these types of trainings, right? And it allowed us to then think creatively. So we took the qualitative data to storytellers and script writers and said, can you help us to make this come to life? And they also used the quantitative data to provide that sort of broader social contextual piece to these stories. And so what we're left with in this instance, so we've got one VR that looks at bias in clinical decision making, and another that is the walking in the shoes of. And for the walking in the shoes of, we use live actors during the pandemic to shoot these 360-degree films so that you're able to either experience the racism firsthand or witness it. And again, it tells you a lot. And so the reactions that we're getting from that are really powerful. And so now it's extended from, not just health and social care, but we've had contact with the Metropolitan Police in Manchester who want to explore that, because it's really about bringing the numbers to life. So, and don't just stop at the narratives themselves. What I'm trying to say is that this, we collaborate with a lot of creative arts because we think that art is communication. And it's a really important way of getting these messages out there as well.
Thank you. I love the fact that we're bringing the data to life, and I think that really makes a difference. When we have had, it's this, the story of thousands, or the data that talks about thousands doesn't sometimes land as much as something that you see, you feel, or the story of one. Really important. But we have a lot of data. We've got the RES data, we've got our staff survey data, we have evidence. Who's looking at the data, and how is that data integrated into the measures of performance that we're all held accountable with?
Well, I would say that they're not, really. I mean, I think that those who, there are certain trusts that do better than others. There are certain leaders who pay more attention than others. But I think overwhelmingly, I sat on the Res Advisory Group before moving on to the NHS Race and Health Observatory Board. And I think there was a level of frustration, including my own, about the res indicators not really having any teeth. And so I sort of cornered Julian earlier, and I said, one of those things has always been, why isn't this a part of how you determine quality and experience within a trust?
So Julian is brilliantly positioned
yes.
now as the leader of CQC.
And also there's that access to data. Data access is a serious issue. And I say this coming from the perspective, someone was saying something earlier about the linkage data. So we're really fortunate in South London to, through our South London and Maudsley NHS Foundation Trust partnership with King's College London, we have an NIHR Biomedical Research Center, which I would say pioneered the anonymization of electronic health records. And then we linked them to primary care. They're also linked to secondary mental health care services, but also hospital episode statistics, cancer registries, mortality data.
Absolutely.
And so there's a group of us, focused around population mental health. We analyze the hell out of that data. We have teams going at it. We take it to policymakers, and and to trusts. We do roadshow. Nothing. We find it's a running joke that we have to keep going again and again and again and again to try, and because we can see the pathways through care, we can see the barriers, we can see the access issues. And then this has been repeated around the country. So there are many locations now that have joined up, the health partnerships.
Absolutely.
Where we're able to do this, but we're not doing enough.
And I think there's still some work to be done. So RES, for example, there's amazing work being done on primary care, RES data. There's work starting on social care, so we actually have a proper system view.
And that's the systems approach that I'm talking about.
But Julian, I'm really keen to understand how we look at well-led from an anti-racism perspective.
No, really, really important question. So, starting point here, I think, is that we know tackling inequalities in health and care, that's core to the purpose for CQC in ensuring high quality care is delivered. And looking at racism in all its forms in terms of interpersonal, institutional, structural. So we know, and you've amplified this clearly in the work that you're doing, Stephani, that we know that the key determinants of health, which that racism worsens all of those key determinants and impacts inequalities. So we have to address this as a regulator across all our functions. Now, on the well-led, we have a specific quality statement on the well-led that is all about an assessment of the workplace in relation to equality, diversity, inclusion. Now, I think it's fair to say that we are going through something of a crisis of confidence in CQC around our ability to have the credibility and the necessary operational effectiveness. And it's been well documented over recent months. However, there's some very good work happening in the organisation on this, and I'd pay tribute to Joyce. Joyce Frederick's here. Where is Joyce? There's Joyce. And Joyce and the team are doing some really important work on this using research to understand. And one of the forthcoming report that we've got coming out based on research is the importance of senior leadership of the organisation really facing into this, because that, the research tells us, gives confidence in the organisation and is effective in building that sense that this is being addressed. So your point about leaders through the organisation, not just at a senior level, but having systems and processes that look at that. So part of the well-led assessment that follows on from that quality statement, we want to make sure we do that effectively. And I think what we were talking about before was how we, in the reorientation of our assessment framework, which is going to be vital, that this is core to it, because we know, going back to continuous improvement, Nnenna, that the more engaged and aligned and involved frontline teams are in any healthcare organisation, often the better the outcomes for people that use services. And crucial in that is the culture of the organisation, creating cultures of compassion, inclusivity, and psychological safety. There is a huge body of evidence that's really clear that those factors can create better care for people that use services, and therefore it's right that we as a regulator focus on those areas and have a clear view. And we're using the NHS Race Observatory kind of framework to address that.
I think a real opportunity for us to hardwire it into how we evaluate and rate organizations. Shan, I'm really keen when you spoke about your experience, and we're going to say that you are now mature in experience, that one of the things we spoke about was the fact that in many ways it feels like very little has changed. And I think in dinner conversation recently, someone reminded me that actually a lot has changed. We can speak about this more than we did before. The NHS, as compared to other industries, is in a better place, but still tremendous amount of work to do to make sure we actually represent our staff in the way they deserve to be represented. And I think that there is absolutely a commitment to do more. My question to you is, the definition of insanity is doing the same thing and hoping for a different result. So I suppose my one question is, what progress have we made? And just to put it out there, when we speak about the riots and the challenge that surfaced, equally beautiful was the passive protest that happened and the stand that was taken by so many people. So there is hope. But what do you think needs to be different about the way we approach this within organizations and across sectors?
Well, I think one of the things is that we need to learn from the business sector, who I think are probably further forward than the NHS and public services, because they recognise the business benefits of a genuinely diverse workforce and respecting cultural difference. And they do it because for them it's about profitability. Well, for us, it can be about productivity. So I think it's about the moral imperative and the business case that we need to get smarter about articulating. And I think I love your challenge about the first thing is name it. We need to do that more. You know, those of us who have been frightened of getting it wrong and therefore saying nothing, well, let's stop being frightened. Let's be more frightened that we do nothing and we don't bring about any change, because that's the worst outcome. And there are so many initiatives for us to draw on. So I referenced earlier some work that's going on in Cambridgeshire and Peterborough. I don't know if you want me to talk about that now. Or...
So I'm going to probably give the audience some time to ask questions. I'm putting you on notice. Think about what you want to ask. But I do possibly, if we have time, we'll come back to that.
Fine, okay.
Thank you. So, over to you. I think there are a number of roving microphones and a number of hands that have automatically gone up. So I'll start in the front. Thank you.
Hi, Sally Gainsbury from Nuffield Trust. Thank you for really interesting presentations and discussion. I wanted to hear your reflections on, because you talked about, seemed to talk about two things: changing and addressing racism and the consequences of racism, and also retelling, it feels like again and again and again, the narrative that it exists. And I was interested in your response to the increasingly hostile climate that retelling is happening in. So even on the news this morning, it was quite incredible, the Criminal Sentencing Board's guidelines that were about recognising the existence of structural racism. And lo and behold, we have Labour ministers queuing up behind opposition spokespeople to reject these. I mean, it was actually, I mean, I felt it was quite gobsmacking. I am sure in the back of their minds are the riots of last summer. In the healthcare example for me would be in the middle of the pandemic, it was patently clear, I think, 9 months in, the fourfold higher death rate in Black and Asian populations. When we got the vaccine, the JCVI, I think that's the right acronym, discussed should minoritized ethnic groups be in the front of the queue or to the top of the queue. And it's in black and white. The reason that was rejected was because of fear of a racist backlash and fear of racial stigmatization. How do organizations talk and think about taking action against racism in that hostile environment?
Thank you. I'm going to gather just a couple more questions and then we'll pose them to the panel. So there are a few hands, I think one in the middle just there. Thank you.
Thank you. Polly Mitchell. I'm a philosopher, and philosophers like distinctions. So I'm going to distinguish between 3 different kinds of equality. There's equality of opportunity, so broadly the opportunities that people have access to. There's equality of outcomes, so broadly like what outcomes people have, health outcomes, well-being outcomes, other social outcomes. And then there's relational equality, which is about seeing one another as equal. And I think that gets relatively little airtime. Without relational equality, you can have some markers of equality, but it's questionable whether you can actually have equality because you still have people having racist attitudes or other discriminatory attitudes. So I guess one question is, how do we drive towards relational equality and thinking about changing underlying attitudes rather than just changing these kind of systemic and institutional markers of equality?
Thank you. And I think there was one more question at the front here before you're all on tender hooks.
Hello, Chand Nagpal. I'm a GP. I am also chair of the BMA's Race Equality Forum and also board member of the NHS Health and Race Observatory. I was going to just say that we should also remember that racist experiences do impact on patient care. The impact of incivility has been shown to reduce cognitive function by about 61%. And high levels of stress amongst individuals can increase the risk of medical error by about 60%. And anyone who experiences that level of discrimination, incivility, all those experiences of microaggressions or racism actually are not able to function as well as they could, and then that can sometimes lead to the disciplinary processes we've heard earlier. But I also wanted to say that we should remind ourselves we all agree with the fundamental principle of the NHS being founded on the principle of equity, and here we are. We don't preside over that equity when it comes to our own workforce. And in fact, being anti-racist is therefore, of course, an important moral obligation on all of us. But I also would like to suggest it would be great if we could move on from being anti-racist to a world where we actually are pro-racial inclusion as an intrinsic value and good in its own right. So we don't actually have to start getting people afraid of not speaking up, but in fact getting people to speak positively about recognizing how much of a kick they may get working in an organization that celebrates and recognizes bringing the best out of everyone. And that, I think, is where we need to get to. We need the right leaders for that. We don't appoint leaders to actually speak about the positive value of inclusion and diversity.
Thank you. So I'm going to just summarize what I think I heard, and I'm going to point, and I'm going to ask for really quite brief responses just so I can have as a broader discussion as possible. We're data rich. We're outcome poor in terms of this discussion, and particularly where it comes to fundamental attitudes and relationships. So what needs to be different about what we do now to make a difference in terms of that outcome? The second element is around, and I might ask Sharon for you to pick this up, we speak a lot about what happens when we get it wrong and less possibly about what happens when we get it right. I'm not going to rehearse the data. We all know the data, whether it's incivility, whether it's cognitive impact, whether it's mental health distress, whether it's time at work, whether it's sickness. In a growth economy, at a time when money is becoming even more important, how do we make sure we're speaking in the currency that will be understood and that will help? And I might get Julian for you to pick that up. And I will start with you, Stephani, around that bit, relational equality and how we fundamentally change attitudes.
That's a good, I think that's a really important one. I'm going to be very blunt and honest. I gave up on that. that's why I turned to be more interested in people's actions, and particularly when they're around people's basic human needs, putting a roof over their head, food in their bellies, that sort of thing. And I'll tell you why, because you told the story of, this sort of life course of being entrenched with these stereotypes and stigma. I don't have, that's an emotional burden that I can't carry to help you fix what your attitude is towards those from racial and ethnic minoritized groups. I think that, I think what's important is that you ask yourself that, because I'm not, as someone from that group, I have no, it's not my responsibility. And I think what I would like to see, and this goes to the response of institutions when they're so much, worried about the racist backlash, I would just encourage people to just be a little bit more courageous.
Thank you. Fantastic. Sharon, positive organizations.
Yeah. So I think there are so many examples. I mean, I was just thinking, look around this room, look at this panel, the talent that we have, that we absolutely need to celebrate. And look around your own organisations. Who is in your organisation that you can support to be able to fulfil their full potential? Because then we all benefit from that. We all learn from difference. We all know groupthink is no good. And I don't know who coined this phrase, but somebody once said at a conversation that diversity is reality, inclusion is a choice. And I like your challenge about be more courageous. Let's all be more courageous about making inclusion the reality, and our rationale for that and our evidence that actually that means everyone wins.
Thank you. And I think that bit around sapping societal benefit, I think is something we need to think about inverting. This is how we contribute to the common pool. Julian, can I speak to you about the hostility, particularly in a financially constrained climate, and how we speak in the right currency?
Absolutely. So I think there's no doubt it's incredibly difficult right now in terms of the scale of the financial challenge, but there is always and always has been this lens with which you can view health and care in terms of the value collectively that it adds rather than separating out the money and the quality. And therefore, the importance around improvement is vital at this time. I think that as a regulator, moving to a view where it's not just a summative assessment, it's a formative one, so an obligation to share and adopt best practice, and thinking about your challenge, Stephani, around the action. When I was fortunate to work with Saffron and colleagues at NHS providers who've done a lot of work on anti-racism and encouraging that in the trust sector, Lewisham and Greenwich had one of the most challenging positions in relation to disciplinary action, but have absolutely moved the dial through a concerted effort in a very organised way to bring the community together to tackle that. So you're right when you say this can be done, we can move the dial on this. So I would say on the hostile environment, the financial challenge, I think that this room has an obligation, because there's, this is a group of people that can set the tone, and the kind of things we write in the media, the positions we take, the approach that we as regulators take, just dealing with some of the narrative and the voices that are creating all sorts of toxicity is vital. And I think on the issue of value and financial challenge, Nnenna, I think that we go all the way back to what constitutes quality. You go back to IHI, its outcomes, its population health, its experience, its inequalities, but it's also efficiency. So it's how we use the resources wisely and well. And I think that it's clear from the most recent report in the Race and Health Observatory that racism actually costs.
Yes.
And the point that Chan made about incivility is absolutely spot on as well, because that has the same impact.
Thank you. And I think what I'm hearing, in addition to the individual responsibilities, there's an opportunity for us to apply systems of improvement, and I think that's important, and that those systems are based on evidence, and that evidence is becoming richer, and it's not just about numbers. Can I just share one concept that has stayed with me through my youth? It's around virtue ethics. And the philosopher in the room will probably correct me on this. There's something about how you practice doing the right thing often enough that it becomes a thing you do. And I just wonder about some of the benefits of the training we've had. And I'll leave us with the other concept of willful blindness that Thea introduced this morning. We can no longer be willfully blind. We can no longer be complicit by silence. Sam, I think you had a question, and there was one other question. Thank you. Is there a microphone for the front? Thank you. And then there's one just in the middle of the room as well. Thank you.
So you really made me think about what have I done over the years that has really made a difference in this territory? And it led me to the question I will ask after just mentioning three things about this 10-year plan. What is in the 10-year plan that actually would really make a difference in terms of equality? So the things I think I've done is the campaigning research. So when we published that, when we sent fake CVs, Indian, English surname, got arrested, charged with fraud, put up in front of the GMC, then investigated them. It was about bringing alive the issue, and I call it campaigning research. Because actually so much of the detail and data is there already, but how do you bring it alive again in the newspapers and at the front of people's minds? The second thing is, in Tower Hamlets, we developed a protected learning time where, as teams in primary care, we all train together. Doctors, nurses, receptionists, everyone trains together. That has been massively powerful in terms of equality and diversity, and you see that when you see young Bangladeshi women standing up in front of a big audience of GPs and speaking. That's the power of what it delivers when you start doing these things together, because you find people are supporting each other much better. And then finally, the social prescribing project. So this is more on the patient side. We've got 100 social prescribing projects at Bromley by Beaumont, but guess what? They bring the community together, and there's not much that does. And I go back to the bombing 20 years ago when I was the senior doctor on site at BMA, and felt deeply afterwards, actually, what an important role we have in the health service, and particularly in primary care, about bringing communities together, because you bomb somebody because you hate them because you don't know them. So the question for us actually is, how do we create the environments within our infrastructures that actually brings people together over lunch or whatever else?
Thank you. And just as the microphone is being located, I just want to call out the courage and to underline again the importance of taking a stand. And that's individual action, but there's also collective action for us.
Hi, can you hear me?
Indeed.
My name is Joyce Frederick, and I'm from the Care Quality Commission, and I wanted to offer some things about your challenge, Stephanie, about what works. I think we've heard clearly today that racism is not an act, it's a system. Mm-hmm. So when people quite naturally talk about, let's think about healthcare, and then let's think about what are determinants, then they must also have racism in that conversation, because racism is the causes of the causes of the health inequality in the first place. So that's the first thing, making it explicit part of those conversations. The second thing is, we've learnt about the impact on staff and then the impact on health outcomes. But it's the staff who have racist attitudes that cause some of the poor health outcomes. So it's not just the people who experience it, it's the attitudes towards patients, like we can see in black women's mental health, and black men's mental health, but black women maternity, when people assume that we've got really high pain thresholds, and we do not. And lots of risks and causes of safety have happened because of that. So this issue about being an anti-racism organisation should be one that everyone adopts. And we at CQC actually do work with you, the RHO, and are adopting your principles, and I think that needs to be more widespread. And the third thing I wanted to mention, this is avoidable. Health inequalities and equity is avoidable. We treat it like it's a natural thing and it will always be here forever and ever. And maybe I'm just not, I've got this kind of godlike vision that actually we will eradicate racism, but why don't we have that big ambition? Why don't we think about eradicating racism? Some of the things, I'll be really quick, but some of the things that we introduce and we think works, like training and policies, don't actually work. There's so much research that's of limited value. So think about where you are in your organisation and think about the things that actually work. There's a huge evidence base built by Roger Clyde and others about what works. Get that evidence base and start introducing some of those actions into organisations.
I'm really grateful, actually, and I'm excited by the possibility of what will follow. No pressure at all. There were two other hands, I think Henrietta and just in the front. So one behind you and one in front of you. Thank you.
Thanks so much. And what I was going to talk about is how deeply ingrained this is in every element of healthcare. So whether it's about the design of devices, as we know from pulse oximeters, from medical textbooks, where we've only recently had an atlas of obstetrics and gynecology with darker toned skin images in it. But it's even in the language that we use in terms of words like jaundice and cyanosis, which imply that the skin in those conditions is yellow or blue. But they're the descriptions that are made. I mean, I'm not even going to go into the APGAR score, which is pink all over, as a way of identifying the health of a newborn baby. The reason why I think this is really important is that when we're designing everything from medical devices through to education, curriculum, materials, and the way that we approach differential attainment in medical schools and in terms of health inequalities for patients, means that we're missing out on really important voices in the design and the delivery of all of these elements. And I think if we focus on what's happening in a provider without considering all of those aspects that create the willful blindness, that sustain it, but also in terms of the way that we act as leaders, professionals, and staff with our patients. I've never seen something around civility or looking at equity as part of chairs and chief execs appraisal frameworks, as part of appraisal, as part of the way that we assess the behaviour of individual people. And it's when we get down to that level of granularity, we start seeing changes in individuals' behaviours, individuals' knowledge, and also we'll start seeing changes in attitude. So I think this is ingrained at many, many different levels in the system.
Thank you, Henrietta. And there was another question from the front.
Thank you. Dr. Ben Bowers, community nurse, clinical academic, University of Cambridge. I'm going to pick up on the theme of nursing because I think it's a really important theme, but what I'm going to say applies beyond nursing to all professional groups and beyond. Awkward question, how does it make people feel when the regulator, in this case the NMC, and also a professional organisation, the RCN, have been called out as institutionally racist? And how does that make people act?
Gosh, so that is a question. I'm not sure I can point at any one member of my panel, but it is an important question to ask, and so thank you for asking it. I think, can I widen the question a little bit? Because there are two organizations that have been called out for something we know exists in multiple other organizations. And other professions. So there is something about, to Henrietta's point, how do we design systems, whether they're systems of regulation, whether they're systems of performance management at individual or organizational level, that actually starts to address this. But there is a bigger question, and Stephanie, I don't know if you want to try and wade into this.
So I just want to say, I always use the example of Welcome. And I don't know how many of you know Welcome as a funder, and you know, one of the, just, they were the ones that funded, about a decade ago, funded the work that I proposed around looking at tackling discrimination being perpetuated by healthcare providers. So we were initially looking at it from the patient and service user perspective, and no one else would fund it. They said it was too controversial. You can't say that. I mean, it was going on and on. I go to Welcome. They funded it. And I always acknowledge them when I speak because that to me took courage. What also took courage is that a couple of years back, Welcome came out very publicly and said that they were institutionally racist. Let that sit. So this major global funder came out and was very transparent about institutional racism within their organization. They followed that up with an evaluation that was made public and transparent. They held the leaders to account, and they have since put in a series of actions to address this. So being called out for that is not the end of the road. It's not you're not walking in shame. The shame comes when you don't do anything to respond to it. And so that's the naming part as well. It's not just for us to name it when we see it, but for those of us in institutions where you've seen the patterns, you've seen it in policies, you've seen it in behaviors, you've seen it in the service design and the way and the training. Are we colluding with that, or are we going to sort of move forward and correct those things? In some ways we are, but we just need to move past this idea that admitting it somehow, it's sort of a road of no return. Because I think that, Welcome's one example, but there have been others, and I think that, that's something that people really do need to take a hard look at.
Thank you. Lovely. There's another question just in the front and one last one here, and then I might just ask the panel to conclude in 2 seconds with maybe 3 key actions you might want to put to us all.
Hi, so my name's Jane Dacre. I'm interested in pay gaps, which are a measure of inequality both for women and also for minority ethnic groups, and I'm delighted that the NHS and the Department of Health and Social Care, I think, are committing to measuring both. I just wanted to say to everybody in the room that actually today is a milestone day, because on the radio this morning, Professor Dame Carrie McEwen was talking about the GMC register for the first time having a majority of women with a license to practice in the medical profession. And actually earlier this year, there was also another statement saying that there is a majority of minority ethnic doctors in the medical profession with a license to practice. So if there are more women than men with a license to practice and more minority ethnic doctors than white doctors with a license to practice, why is this still going on?
And that is the quintessential question. Hold that thought. There was another question just here. Final question. Thank you.
Hi, my name is Dee Thirachelvam. I'm the Chief Nursing Officer for NHS Blood and Transplant. And I've got 2 points. As an organisation, NHS Blood and Transplant, if you Googled us from a racism perspective, would probably not come up with some positive narratives. And we went through a piecework for a number of years, trying to build trust back with the organisation. And actually, there is something about taking, and I utterly respect the accountability as leadership, to actually say, do you know what? We want to be an anti-racist organisation, but we got it wrong. We have had environments, we've had situations where we made the wrong decision, but as a leadership, we're owning that. Now, we've been called out as an organisation of why are we saying that we want to be anti-racist, when in fact, actually, we should be inclusive in all practices. But I think we have to start with being explicit about what went wrong, the mistakes we've made, own it, build the trust back with our employees, but also the public, because ultimately, we don't exist without donors.
Thank you.
And the second point is, I am one of only 25 chief nursing officers at a board level from an ethnic minority. Now, bearing in mind, there are hundreds of providers across this country. We are still utterly unrepresented at a leadership position. Now, that is better than when I started, because it was 10 when I started as a CNO just under 10 years ago. Now, look at this room, and we're still not represented. So again, as a leadership and a panel, whilst it's getting better, it's not quite where it needs to be. And what can we do to accelerate that?
Thank you. So with that resounding in our ears, which is a reasonable challenge, Two things, a lot more to do, without any doubt. And we are getting better in some corners around representation. So your question, why is this still an issue? So I'll leave that with yourself, Stephani, just because you take the nice hard questions. And the second question is just an acknowledgement, isn't it? There is a lot more to do. And you're right, we look at the room here today. We look at our organizations. Representation is the first part of where we get to. So let's recognize the challenge. Stephani, if I can get you to maybe pick up that question and then leave us with 3 key bullet points.
Sure. So I think that publicly saying you got it wrong is part of the process, right? It goes back to not wanting to admit, get it wrong in a conversation around race. I think actually, making that statement. But I also want to say, engaging in anti-racism practice and inclusive practice, that's not an either or, that's an and. So you can do both things. So, sort of give yourself these opportunities to work in very agile manners, right? So that you may get some things wrong and you have to sort of move ahead. My 3 things, and it won't be a surprise. One is to focus, to walk away from here, if nothing else, to focus on inclusion as a practice in your daily work. 2, to shift to thinking about better understanding mechanisms and to focus equally on these inequality diversions, right? Why are some people being unfairly advantaged? And 3, and this is probably the most important thing, to collectively work across sectors to develop systems solutions, right? System level solutions with attention to power and accountability.
Thank you. Julian.
So number 1, to continue the work that CQC has actually started on being an anti-racist organisation, following the key steps, the key phases that the NHS Race and Health Observatory set out. Number 2, developing the work on our anti-discriminatory workplaces in the well-led framework and getting that right in the context of reviewing our assessment framework. And 3, addressing the deep concern that I heard from colleagues at the Council of Royal College of GPs about our assessment of general practice in relation to race. So those would be my 3.
Thank you. Sharon.
I think we all need to be courageously curious and go back and have the conversations. In my own organisation, we've been doing a lot of work around community engagement, seeking out those people who are not represented as they should be, either in our workforce, our volunteer base, or as people accessing our services, because this is about building relationships of trust, and it is about having the conversations, not shying away from this. So one thing we can all do is not feel we can do nothing. Don't go away thinking I'm just or I'm not in a position to. We are all in a position, and we will see and hear things every day. Do something, say something, speak up, put forward a proposal to change things. And I think the representation point is so important. Look at your organisation and work out where you need to take action.
Thank you. I'm going to say thank you to our panel. This conversation could continue. I think it is incredibly difficult to understand the challenge that is facing individuals and society as a whole at this moment in time. And I think that is represented by actual fear. And there's something we need to realize in the commitment we make as we leave this room. I want to say thank you, and if you can show your appreciation to our panel today, please.